I have performed thousands of procedures over 2 decades, but the moment that changed everything was not in the operating room. It was in a waiting room. I was holding the hand of a 73-year-old woman who had just come out of what her surgeon had called a routine spinal fusion. She went in walking on her own 2 feet. She came out in a wheelchair, and what nobody told her family was this: that surgery should never have happened, not to her body, not at that moment in her health history, not with what I could see in her chart when I finally reviewed it. So let me ask you something right now. If you are over 60 and a surgeon is recommending a procedure, are you asking the right questions? Because most people are not, and that silence is costing some of them everything. I know what you are thinking right now. This cannot be happening to me. But before you move on, I need you to stay with me, because in the next 35 minutes, I am going to walk you through 5 surgeries that carry serious hidden risks for people over 60. And I am going to give you the exact questions, the warning signs, and the preparation tools to protect yourself, or to protect someone you love who may be facing this decision right now. Before we go any further, I need to say something clearly. I am not here to frighten you away from surgery. Surgery saves lives. I have been part of that work, and I believe in it. But what I am here to tell you is that surgery in a body over 60 is fundamentally different from surgery in a body over 40. And that difference is not being explained to patients clearly enough. Everything I share today is based on published clinical research and real experience treating older adults. Please continue working with your own physician. This conversation is meant to add to that relationship, not replace it. Now, let me tell you what I have learned. Before we go deeper, I want to hear from you. Have you or someone close to you ever been pushed toward a surgery you were not entirely sure about? Drop a yes or a no in the comments right now. It takes 1 second, and it tells me exactly what this community is actually dealing with. Here is something medicine does not say out loud enough. When an older body goes under general anesthesia, a cascade begins that most patients are never warned about. The heart has to work significantly harder during the procedure. The lungs take longer to clear the anesthetic drugs. The kidneys slow down their processing of medications. And the brain, this is the one that surprises people the most. The brain can become temporarily disoriented in ways that last weeks or even months after the surgery is over. Doctors have a name for this: postoperative cognitive dysfunction. In patients over 70, it happens far more often than any pre-surgical conversation admits. Now I want to be absolutely clear. Age alone is not a reason to avoid surgery. I have treated patients in their 80s who bounced back faster than some people in their 50s. But frailty is different. Frailty is a specific medical term. It means the body's reserves have dropped below a critical threshold. Roughly 40% of people over 75 show measurable signs of frailty. That number climbs towards 60% once you cross 85, and this matters enormously. Here's the way I explain it to families. A young body going into surgery is like a new car going in for a major repair. Full tank, strong engine, plenty of reserve, the work gets done, the car drives out stronger, but an older body with frailty is more like a car that has been running on reserve for years. The engine still works, but the margin for error is gone. One unexpected complication in a younger body is a bump in the road. In a frail older body, that same complication can become the beginning of a cascade that is very difficult to reverse. That is the real variable, not the surgery, recovery. And that distinction matters deeply for everything we are about to cover. Surgery number 1, open heart surgery in frail patients. Coronary artery bypass grafting is one of the most common major surgeries performed on older adults. The concept sounds straightforward. Your arteries are blocked. We reroute the blood flow around the blockage, and for the right patient in the right condition, it is genuinely life-saving. I have seen it transform people. But here is what the brochure sitting in the waiting room does not show you. Open heart surgery requires stopping your heart completely. You are placed on a bypass machine, a mechanical device that does the work of your heart and lungs, while the surgical team operates on your stopped, still chest. For a fit 60-year-old with no other serious conditions, that is medically manageable. But for a 78-year-old with kidney disease, early cognitive changes, and poorly controlled diabetes, that bypass machine is a simultaneous assault on every organ in the body at the same time. The kidneys, which were already struggling, now have to process an enormous load of medications and bypass chemicals. The brain, which was already susceptible, is now running on mechanically circulated blood for hours. And the inflammatory response that the body launches just from being opened up can destabilize systems that were barely in balance beforehand. Here is the number that stops people cold when I share it. In frail elderly patients, open heart surgery carries a 30 to 40% risk of major complications: stroke, kidney failure requiring dialysis, extended time on a mechanical ventilator, weeks of profound confusion, 30 to 40%. And in the highest risk group of all, up to 15% of patients do not survive the first 30 days after the surgery, not from their heart disease, from the surgery itself. But here is what your cardiologist may not be leading with in that 12-minute appointment. In many cases today, there is a less invasive alternative that simply did not exist 15 years ago. It is called TAVR, transcatheter aortic valve replacement, a catheter-based procedure where a new valve is threaded through a blood vessel in the leg and delivered to the heart. The chest never opens, the heart never stops, the body never goes on bypass. The recovery is measured in days rather than months. For a frail older patient, this is not a compromise. For many, it is actually the better clinical choice. Does this mean refuse heart surgery if your cardiologist recommends it? Absolutely not. It means ask one specific question before you sign anything. Am I a candidate for a less invasive approach? That single question, asked directly and calmly, could change the entire conversation. Now let me tell you about a patient I want to call Robert. He represents a pattern I have seen more times than I can count in 2 decades of practice. Robert is 71 years old, retired engineer from Texas, methodical, careful, the kind of man who reads the fine print on everything. He came to me after 3 different cardiac surgeons had each independently recommended open heart bypass surgery for a blocked coronary artery. 3 consultations, 3 identical recommendations. Not one of those surgeons had spent more than 15 minutes discussing alternatives. Robert was not afraid of surgery on principle. What he was carrying into my office was something more specific than that. 2 years earlier, his wife Beverly had undergone major hip surgery. She was 68 at the time, and she had mild chronic kidney disease that everyone knew about, but nobody had paid particular attention to when scheduling her procedure. The surgery itself was technically successful, but Beverly's kidneys struggled to clear the anesthetic. She developed post-operative delirium. For nearly 3 weeks, she did not consistently know where she was. Her children would come to sit with her, and she would ask for them by name, not recognizing that they were already in the room. She would have moments of lucidity followed by hours of confusion. She came home eventually. She did recover, slowly and incompletely, but something in the sharpness and warmth that Robert had known for 40 years, some of it never fully returned. The woman who came home was Beverly, but a quieter, less present version, and Robert was carrying every memory of those 3 weeks into my consultation room. He told me, "I am not afraid of pain. I am afraid of going in as myself and coming out as someone my grandchildren look at differently. I want you to hold Robert's story, because it is not finished yet. We will come back to him. Surgery number 2, aggressive spinal surgery." Back pain over 60 is essentially universal. I have never met a patient over 70 who has not mentioned their back in some form, and the solution being offered more and more frequently is spinal fusion, multiple vertebrae locked together with hardware. The logic sounds compelling in the office. We fix the unstable segment, we decompress the nerve, you stop hurting. And for certain specific conditions, this surgery is absolutely critical, and I would recommend it without hesitation. A spinal cord being actively compressed, causing progressive weakness or loss of bladder control, needs surgical intervention right away. No debate, no delay. But elective spinal fusion for chronic degenerative back pain in elderly patients? The evidence here is one of the most underreported stories in medicine. A major study published in the journal Spine examined patients over 65 who underwent complex spinal fusion. The complication rate exceeded 40%. 40%, not minor discomfort, real complications. Blood clots that required additional treatment, wound infections, hardware failure requiring a second surgery, and something called adjacent segment disease, which deserves a moment of your attention. When you fuse one section of the spine and lock it permanently in place, the vertebrae directly above and below that fused segment must now absorb all the movement that the fused section no longer handles. Over months and years, those neighboring segments break down at an accelerated rate. You solve one problem, and you create the conditions for several more. Here is what frustrates me most. Studies consistently show that for many elderly patients with degenerative spine disease, aggressive surgical fusion provides no better long-term pain relief than a structured program of physical therapy, targeted injections, and careful activity modification. The same outcomes at 12 months and at 2 years, but with dramatically higher risk to get there. I had a patient I will call Sandra, 67 years old, retired postal worker from Virginia. Two different spine surgeons had told her fusion was her only real option. She came for a third opinion. I referred her instead to a physiatrist who specializes in rehabilitation. Sandra committed to a 6-month program of physical therapy, targeted injections, and core strengthening. At 6 months, she called me. The pain was not entirely gone, but she was gardening again. She was sleeping through the night. She told me she was grateful nobody had put hardware in her back. Sometimes the best procedure is the one that never happens. Surgery number 3, major cancer resections. This is the hardest one to discuss because the moment someone hears the word cancer, the emotional response is immediate and completely understandable. Cut it out, remove it, get rid of it before it spreads. I understand that reaction. I have felt it myself when people I care about receive that diagnosis. But here is what 2 decades of surgery has taught me about this specific situation. The goal of cancer treatment is not to remove the tumor. The goal is to give the patient more good years of life. Those are not always the same thing, and the difference between them is a conversation that does not always happen. Let me give you a concrete example. The Whipple procedure, surgery for pancreatic cancer. It is one of the most complex operations in all of medicine. In a single procedure, we remove the head of the pancreas, a portion of the small intestine, the gallbladder, and part of the bile duct. The surgery runs 6 to 10 hours. In a younger, otherwise healthy patient, it can genuinely be life-saving. In an 80-year-old with established heart disease and reduced kidney function, the surgery can technically succeed. The imaging shows the tumor is gone, and the patient can still die within weeks from surgical complications, not from the cancer, from the operation, from the body's inability to recover from the assault of the procedure itself. There is a term for this in surgical medicine, futile surgery. And a landmark study from the American College of Surgeons found that nearly 1 in 5 elderly cancer patients who underwent major tumor resection experienced what researchers call failure to rescue. A serious complication occurred, and the already weakened body simply could not fight its way back. These are not failures of surgical technique. They are failures of patient selection, the wrong patient for the right operation. Now, I want to say something to the families listening to this, because this section is not just for patients. When your parent or your spouse or your sibling receives a cancer diagnosis, the pressure to do something immediate and aggressive is intense. It comes from love, and it is completely natural, but the most loving thing you can do in that moment is slow down long enough to ask the oncologist a specific question. If we do not pursue surgery, what does watchful waiting look like? What does radiation look like? What does targeted therapy look like for someone with this specific health profile and age? That question opens a door that many families never knew existed, and sometimes what is behind that door is genuinely better than what is behind the surgical suite. Now let me come back to Robert. When I finally sat down with his complete medical picture, his kidney function, his formal frailty assessment, his cognitive baseline testing, his full medication list, something became apparent that none of the 3 previous surgeons had taken the time to assemble. Surgery was an option, yes, but it was not the only option. An aggressive medical management protocol combined with supervised cardiac rehabilitation had comparable 5-year outcomes for his specific clinical profile. This information had never been placed in front of him before. Not once in 3 separate surgical consultations. He had been told he needed surgery. Not that surgery was one of several reasonable paths. Surgery number 4, elective joint replacement in severely ill patients. I want to be genuinely clear here before we go any further. Hip and knee replacements are among the most successfully developed surgical procedures in the history of modern medicine. I mean that sincerely. For the right patient, a new hip joint can completely transform quality of life. I have seen patients go from barely being able to cross their own living room to playing with grandchildren on the floor within a year. That transformation is real, and it is remarkable. But here is the nuance that gets lost. The word elective means planned, not an emergency. You have time, and time is exactly what you should use to ask whether your body is in the best possible position for everything that comes after the surgery. Because here is what the data consistently shows. In patients over 75 who are carrying 3 or more serious health conditions simultaneously, heart disease, poorly controlled diabetes, chronic kidney disease, significant obesity, elective joint replacement carries a substantially elevated risk of what happens in the days and weeks after they leave the operating room. Blood clots are the primary danger. Deep vein thrombosis, clots forming in the leg veins, can break free and travel to the lungs, where they become pulmonary embolisms, life-threatening. In elderly patients with already reduced circulation and limited mobility, this risk is meaningfully higher than in a fit 55-year-old having the same procedure. Add to that the risk of post-operative pneumonia from extended periods of reduced movement. Add hospital-acquired infections in a body whose immune system is already running below its peak. Add the cognitive effects of anesthesia in someone who is already showing early changes. The full picture is considerably more complex than the before and after photographs in the orthopedic waiting room suggest. The key question is not whether you should have this surgery at some point. The question is whether your body is in the best position it can possibly be in before you walk through those doors. Because here is something important that most patients do not know. Optimizing your blood pressure, your blood sugar, your cardiovascular fitness, your nutritional status, and your muscle strength before elective surgery can reduce complication rates significantly. Not slightly, significantly. Some hospitals have now implemented what they call prehabilitation programs, medically supervised physical and nutritional preparation that must be completed before a high-risk elective procedure is scheduled. And the outcomes data behind this approach is genuinely compelling. Have you ever heard the word prehabilitation before today? Drop it in the comments if you have, because most people have not, and they absolutely should. If this information is helping you think more clearly about a decision you or someone close to you may be facing, hit the like button right now. It costs you nothing, but it tells the algorithm that people need to see this. And stay with me, because what comes next, the fifth surgery, the 4 questions, and the section about what a genuinely good surgical consultation actually looks like, that is where everything we have covered becomes something you can actually use. Surgery number 5, emergency abdominal surgery. I need to pause before we get to the practical tools, because this 5th surgery is fundamentally different from everything we have covered. You do not choose emergency surgery. It chooses you. A perforated bowel, a ruptured appendix, internal bleeding that cannot be controlled by any other means. These situations do not allow for calm second opinions or scheduled pre-surgical preparation. But here is exactly why this surgery belongs on this list. Knowing the risks before the emergency happens changes how you and your family respond in those terrifying moments when someone you love is being wheeled toward an operating room and every second feels like a wall closing in on all sides. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates in all of surgery. In the most severe cases, the numbers run from 30 to 50%, and I want to be direct with you about why. This is not because surgeons are less skilled in emergency settings. The technical quality of emergency surgical care is exceptional. The problem is physiological. An elderly body under sudden massive trauma is fighting on every front simultaneously. The liver, the kidneys, the heart, the lungs, the immune system, they all get hit at the same moment. The inflammatory response that a younger body modulates and controls within a few days can spiral in an older body into what is called systemic inflammatory response syndrome. When multiple organ systems begin to fail in sequence, the situation becomes precisely as serious as those words sound. So what can you actually do with this information? 2 concrete things. First, do not ignore abdominal symptoms. Persistent pain that is new or different, bloating that does not resolve in a few hours, unexplained changes in bowel habits, especially in someone over 60. These deserve prompt medical attention, not tomorrow, this week. Catching what might become an emergency while it is still a manageable problem is worth every inconvenient appointment. That single habit, treating early symptoms seriously, can genuinely change the outcome. Second, have the conversation with your family now, while you are calm, while there is no crisis. What are your wishes if emergency surgery becomes the only remaining option? What does quality of life mean to you personally? What level of intervention do you want and under what circumstances? These conversations are not morbid. I promise you they are not. They are one of the most practical and loving things you can do for the people who will be standing in that corridor trying to make decisions on your behalf in the worst moments of their lives. Now let us talk about the most practical things I can give you today, because knowing the risk is only useful if you know what to do about it. 4 questions. Every patient over 60 should ask these before agreeing to any major surgery. Write them down, take a picture of the screen, whatever helps you remember. Question 1. What happens if I do not have this surgery right now? A good surgeon gives you a specific clinical picture of what the next 6 to 12 months looks like without the procedure, not a vague warning. A real answer. If nothing urgent changes in the near term, you have time. Time to think. Time for a second opinion. Time to prepare your body. Use that time. Question 2. Is there a less invasive alternative? Medicine has changed dramatically in the past 15 years. Robotic approaches, endoscopic procedures, catheter-based interventions for cardiac and vascular conditions, supervised rehabilitation for musculoskeletal problems, options that did not exist when the current standard of care was written, are now available at most major medical centers. If none of these came up in your consultation, it does not mean they do not exist. It means they were not brought to the table. Question 3. What does recovery realistically look like for someone my age and my specific health profile? Not the average patient, not the brochure photograph. You, your specific kidney function, your current medication interactions, your living situation, and who is there to help you, your prior experience with anesthesia, if you have had any. The answer to this question should be specific, honest, and include the parts that are genuinely difficult, not just the optimistic projection. Question 4. What is your personal complication rate for this specific procedure in patients over 70? This is the one most people never ask. Surgeons track their outcomes. Every serious surgeon knows their numbers. A confident, experienced surgeon will tell you directly. They will give you a range. They will explain what complications they have seen and how they were managed. If this question creates visible discomfort or deflection, pay very careful attention to that reaction. It is telling you something. Now, let me show you the warning signs in a consultation itself, because the way a surgery is presented to you tells you almost as much as the surgery does. Red flag number 1, you are being rushed. We need to schedule this quickly. For a genuine medical emergency, yes, urgency is appropriate, but for a planned elective procedure, real urgency is rare. A knee that has ached for 8 years does not suddenly need to be replaced this specific month without a new clinical reason. If the pressure to decide quickly feels unusual, ask, what specifically has changed that makes this time-sensitive right now? Red flag number 2, only one path. You leave the consultation with exactly one option discussed: surgery. No mention of what alternatives exist. No discussion of what watchful waiting looks like. Remember what I said. There is almost always more than one road. If no alternatives were put on the table, it does not mean they do not exist. Red flag number 3, your questions create deflection. You ask, what are my alternatives? You ask, what happens if I wait? You ask for complication rates, and instead of direct answers, you get reassurances without information, or impatience, or a shift in subject. A surgeon who has done this work with integrity does not become defensive when a patient asks the exact questions that surgeon would demand on behalf of their own family member. Discomfort with your questions is itself a clinical finding. Red flag number 4, vague recovery descriptions. You will be back on your feet in no time. That is not a recovery plan. That is a sales line. The honest version of this conversation sounds completely different. It says, here is what the first week looks like. Here is when you will realistically need assistance. Here is the part that most patients find hardest. Here is what we watch for that would bring you back in. Specificity in the recovery conversation signals respect. Cheerful vagueness signals that someone is managing your feelings instead of equipping your decision. Now let me show you what good actually looks like, because I have spent this conversation describing what to watch out for. And I want to give you an equally clear picture of what a genuinely excellent surgical consultation sounds like, so that when you encounter it, you recognize it and you trust it. A good surgical consultation slows down. The surgeon explains the problem in language that does not require a medical degree to follow. They name the risks before you have to ask. They describe the alternatives unprompted, and the very best of them say the words you are hoping to hear. If you want a second opinion, I think that is reasonable. Here is who I would send my own family member to. When you hear those words, you have found someone you can trust. A good surgeon does not schedule around their calendar. They ask about yours, about your support system, about what you are most afraid of losing, because the goal is not the procedure. The goal is your quality of life afterward. Now, I want to tell you something that most patients never get access to, because it can change your outcomes more than almost anything that happens inside the operating room. What you do in the 2 to 4 weeks before you walk through those doors. Most patients spend zero time on this. Surgeons invest years mastering technique, but almost nobody invests 2 weeks preparing the body that has to survive the procedure. Let us change that right now. The first piece is prehabilitation. Walk every single day in the weeks before your surgery, even just around the block. Stronger legs and lungs going in means faster movement after, and movement in the early post-operative days is what prevents blood clots and pneumonia. Most of the serious complications we discussed become meaningfully less likely when a patient gets up and moves within the first day or two. Eat more protein. Your body rebuilds tissue with protein as its primary material. Most people over 60 are chronically under-eating it, and if you smoke, stopping even 2 weeks before surgery measurably lowers your risk of wound complications and breathing problems. 2 weeks, that is all. The second piece is the conversation that almost nobody has before surgery, the conversation with your anesthesiologist. Post-operative cognitive dysfunction is real, and it is far more common in older patients than families are told. But there are practical steps that meaningfully lower the risk. Request a preoperative anesthesia consultation before the day of your surgery, not in the pre-op area with 10 minutes to go. A scheduled appointment where you have time to talk. Bring a complete list of every single medication and supplement you take. Include the fish oil, include the herbal sleep aid, include the vitamin D and the magnesium and whatever else is in the cabinet. Some of these interact with anesthetic agents in ways that genuinely surprise even experienced practitioners. Ask whether regional or spinal anesthesia, where the surgical area is numbed rather than putting your entire brain under general anesthesia, is an option for your specific procedure. For many hip and knee operations, it absolutely is, and it tends to be gentler on an older brain. And here is something that sounds almost too simple to matter. Ask to keep your hearing aids and your glasses with you right up until the moment the procedure begins, and ask to have them back the very moment you wake up in recovery. Patients who can see and hear clearly when they regain consciousness experience significantly less post-operative confusion. The research on hospital delirium is unambiguous on this point, and it costs nothing to ask for. The third piece is setting up your home before the surgery happens, not after, not while you are still in the hospital. Now, while you have the clarity and the energy to plan, who will drive you home from the hospital? Who will stay with you through the first 72 hours because those hours matter most? Are there rugs on the floor or power cords running across walkways where a fall could happen? Falls in the first week after surgery can set back a recovery by months. Are all prescriptions filled and waiting at home? Are there prepared meals in the freezer so that whoever is caring for you does not have to cook from scratch while also monitoring your recovery? The first 3 days home set the tone for everything that follows. A body that is not fighting an unexpected obstacle heals faster and more completely. Now, let me come back to Robert one final time. When I sat with him for 40 minutes, not the 12 that most surgical consultations allow, but 40, and laid out every option completely honestly, something shifted in the room. He asked questions I had not heard from a patient in years. He asked about his kidneys. He asked about what Beverly's experience told us about his own risk profile, since they had similar baseline kidney function. He asked what cardiac rehabilitation would look like specifically, week by week, not as a concept. And then he made a choice. He chose the non-surgical path, medical management combined with a supervised cardiac rehabilitation program, careful monthly monitoring, a protocol built specifically around his body and his history. That was 4 years ago. Last month, he sent me something, not an email, a photograph. He is standing at the top of a hiking trail somewhere in Colorado. His 2 granddaughters are on either side of him, both taller than he is now. Everyone grinning in the kind of way that only happens when you feel genuinely well. At the bottom of the image, he had written 4 words, just 4, I chose right. I want to be honest with you about something. Robert's outcome was on the better end of what I typically see. Not everyone who chooses a non-surgical path does as well as he did, as quickly as he did. Some patients take longer. Some conditions genuinely require surgery, and the non-surgical path offers less relief. What matters is not that you choose what Robert chose. What matters is that you choose with full information in your hands, not just the fraction of information that fits into a calendar-driven 12-minute consultation. Let me bring everything together. 5 surgeries that carry serious hidden risks for people over 60. Open heart surgery in frail patients, where less invasive catheter-based alternatives often exist and should always be explored before the chest is opened. Aggressive spinal fusion, where the evidence for long-term pain relief is weaker than most patients are led to believe, and where conservative management produces comparable outcomes at significantly lower risk. Major cancer resections, where the goal must always be more good years of life, not simply the removal of tissue. Elective joint replacement in severely ill patients, where timing and preparation matter as profoundly as the surgery itself. An emergency abdominal surgery, where the most powerful thing you can do is address symptoms early and have honest conversations with your family before any crisis arrives. None of this is an argument against surgery. Surgery is one of the most powerful tools in medicine. The argument is for information, for slowing down long enough to ask the 4 questions, for recognizing the 4 red flags, for preparing your body before you go in, for bringing someone with you who can listen when you cannot, for getting a second opinion because every surgeon worth trusting expects that request and welcomes it. Your age is not a weakness. Your experience is not a limitation. It is the thing that gives you the right to slow down and demand a complete conversation. You are not a passive recipient of whatever a calendar and a surgical schedule dictates. You are an active participant in your own care, and that participation, informed, specific, unhurried participation, is the most powerful tool available to any patient, more powerful than any operation I have ever performed. So here is what I want you to do before this day is over. Write down the 4 questions. Put them somewhere you can find them if you need them. Share this video with one person who is facing a surgical decision or who might be facing one soon, not because I asked you to, because you now understand something about this topic that most people do not, and that understanding is worth passing on. Your parent, your sibling, your closest friend, one person, that one conversation might change everything for them. Come back in the comments and tell me, which of these 5 surgeries surprised you most? I read every response, every single one. Do not let anyone tell you it is too late, because it is not. Take care of yourselves. Stay curious. Keep advocating for your health. You deserve a surgeon who explains everything and a medical team that treats you as a partner in every decision. And I will be right here next week with more.